Jenny, thank you so much for inviting us and giving us the opportunity to speak today. New York is a big city. We have a lot of myeloma doctors. Patients like to have second opinions. I see so many familiar faces, and maybe I saw one or the other years ago. So it's great to see you. I recognize somebody. So please come to me and let me know how your journey went. Most of you are doing very well. As Ruben mentioned, myeloma is not only our job, it's our life. So to see you sitting here in a complete remission or gaining weight, that's our biggest treat, because that is really great and really makes us happy, and is the reason why we come out on a Saturday. Because what can you do more than helping patients to have a good and healthy life with myeloma? Alrighty, so bone disease. I thought it's very important to talk bone disease. It's a little bit forgotten in the past. We have so many new myeloma treatments that I think we somehow do not mention myeloma bone disease that much, but it might affect almost each of you. So I thought I'd start with just a brief separation, what types of myeloma we have. And when we talk about MGUS, smoldering myeloma, and multiple myeloma, what does it really mean? Do you see my cursor? Yeah. So each of you with multiple myeloma had a prephase of MGUS. That might be a silent prephase. Sometimes you your doctor did some blood work but didn't check a monoclonal protein and didn't realize that. Also, MGUS is pretty common. So around 3 to 5% of patients who are over 70, or healthy individuals over 70, have an MGUS. So it's not an unusual, and most of my patient population actually has an MGUS. So that's a majority of patients, and they're very stable. But unfortunately, MGUS can turn into smoldering multiple myeloma. What's the difference? It's the quantity. If you have, for instance, more than 10% plasma cells in your bone marrow, technically we cannot call that MGUS, monoclonal gammopathy of unknown significance. We call that smoldering myeloma. Also, the protein amount, the monoclonal protein produced by the plasma cells, is relatively low. And as Dr. Nisvitsky mentioned, you don't have any myeloma-defining event. What is a myeloma-defining event? Myeloma-defining event is when you develop a Krebs criteria. So that can be, for instance, and I just repeat that, a high calcium. It can be renal failure, anemia, or bone disease. And recently, because nobody wants to wait, if you know you have smoldering multiple myeloma, you don't want to wait until you have a big lytic lesion in your bones and a fracture, or if you have renal failure and you might need dialysis, or your renal failure is so bad that it impacts the life. So that's why recently the International Myeloma Working Group expanded the criteria to allow the doctors to treat the myeloma earlier, before really the organ damage is bad. So for instance, if your plasma cells in your bone marrow are pretty high, over 60%, we know that those patients have active multiple myeloma and might develop bone disease very soon. So we can right now call this also active myeloma and treat patients, or if they have a serum free light chain ratio. Free light chains, you know what the free light chains are? Help me. You have kappa and lambda. Yeah, those free light chains. If this ratio is above 100, we can start treatment, or if there's a focal lesion by MRI. And since it is so important to make sure that we don't overlook lesions in the bone, I thought I give you a little bit in introduction. How do we image this? Because the imaging of bones to find bone disease is very heterogeneous. And I'm sure all of you had some type of imaging, but there's not an agreement what is the best. But let's start. Metastatic bone survey, skeletal survey. Who had a skeletal survey? Tell me. Almost all myeloma. Is there any myeloma patient who didn't have a skeletal survey?
That's an X-ray.
The X-ray, the regular X-ray skeletal survey, yeah. It's very common, and it's, unfortunately, I have to say, and we did it, still the gold standard. So what do we do with this? We X-ray all the bones, the skull, the spine, the arms, the pelvis, and also the legs. But you can see that, especially in the pelvis, where you have a lot of gas from your GI tract, from your bowels, that, or in your vertebral spine, that is very difficult. It's not a straight bone. It can be very difficult to really see lytic lesions, and it's relatively insensitive. So you have to lose, and I have that here, 30% of your bone before we see a lytic lesion. So we are not really happy with the bone surveys, but the problem is Doctors are also restricted what insurance would pay, for instance, and how much radiation exposure we can give to the patient. But nevertheless, in the beginning, it's important that we make the right diagnosis. Skeletal survey, still the gold standard, but there will be a recommendation from the International Myeloma Working Group that we switch that to a PET-CT or to a low-dose whole-body CT scan. CT scan is much more sensitive than an X-ray, and you probably, anybody who had bone pain in the spine or maybe in the pelvis, I'm sure that your doctor said, let's do a CT scan because that gives me better information whether there's bone destruction. I mentioned here low-dose whole-body CT. We hope that this will be the future and will replace the regular X-ray. What does it mean? It's a CT scan from head to toe. And we can modulate the radiation exposure that we have a very low dose. In Europe, it's standard of care. Europe completely stopped to do conventional X-ray, skeletal surveys, and replaced it with a low-dose whole-body CT scan. But unfortunately, in the US and also in Canada, we are a little bit behind on this in this area. If we call insurance and say we want to do a low-dose whole-body CT scan, they say, what is this? We don't have a number for this. And radiology cannot even write a bill because there's no billing number. So it's complicated, but we hope that will change soon. So patients maybe in Colombia had a low-dose whole-body CT scan. I think you will hear about this in the future. PET-CT, who had a PET-CT? PET-CT? Most of you. I think that's kind of, the gold standard also in the US. If you go to an academic center, I think most of the physicians would do a PET-CT initially. It's, again, combines a CT scan with the PET portion. You get a sugar solution injected, injected, and the sugar will go to the areas of high activity. So myeloma is very active. It needs a lot of sugar, it has a high cell growth. And that's why the PET portion of the CT scan will show you areas of active multiple myeloma. The problem is, if you have inflammation, for instance, in your body, diverticulosis, a bad tooth, the sugar will also go to those areas and it can be a little bit misguiding. So we sometimes have to figure out, what is it? Is it a myeloma or is it the underlying inflammation or is it the secondary cancer? MRI. So MRI is, I would say, the latest tool in our armamentarium for evaluation of bone disease. The MRI does not really show you a lytic lesion. You know, by the way, what a lytic lesion is when I talk about a lytic lesion? A lytic lesion is a hole in the bone, yeah? You remember the slide Dr. Nisvitsky showed you with a mummy skull, that black dot, that is a hole in the bone. The plasma cells or the myeloma cells eat the bone and you have a hole in the bone. And we know from studies, when you do an MRI, that before you develop a hole in the bone, the plasma cells sit in that area and the MRI shows you very nice plasma cell nests. And we know that patients who have those plasma cell nests, what you see, for instance, here in white, you see those white dots, those are plasma cell nests. In this area, they will eat the bone. And we know that those patients might develop lytic lesions. So with those plasma cell nests in the MRI, we are allowed to start treatment. And that's why we do also more MRIs. And the development is going into the direction of whole body MRIs. I'm not sure who will pay for this, whether insurance will pay for this, but I think we should do that in selected cases. For instance, young patients with an M spike and it's not and a negative skeletal survey or negative PET-CT, and we don't know, is it really multiple myeloma? Bone marrow shows 50% plasma cell infiltration. We feel somehow something is going on there. In those cases, I would absolutely fight with insurance for a whole body MRI in order to detect those, white spots, because they might not show up in a conventional X-ray. So MRI is also important, and again, especially if you have multiple myeloma in your spine, then the doctor will probably very often do an MRI because the MRI shows you is there cord compression, the nerves are compressed. So that is, I would say, a very elegant tool also to see the multiple myeloma infiltration. So let's say we see multiple myeloma, bone disease in the spine. What can we do? I mentioned here surgical corrections. If it is really bad and you have, for instance, pending cord compression, this is an emergency. So for instance, what I always tell my nurses, and I think I have Monique here, if she says, oh, the patient complains about, by the way, Monique is here. Thank you for coming. Yeah, that's really great. If we just had the case last week that some patient complained about weakness in his legs. So I went ballistic and I said, oh my goodness, we need a CT scan. We need to make sure that the weakness is not from cord compression. And some of the patients, and I know this, had this weakness. So if you have any weakness in your spine, really let your doctor know. And in those patients, sometimes we have to do a major surgery to decompress the cord if, for instance, the myeloma tumor compresses on the cord. But there are surgical corrections which are not that dramatic. For instance, a kyphoplasty. Anybody with a kyphoplasty here? One, only one. When did you have the kyphoplasty?
2004.
2004, yeah. We barely, I mentioned that, and I tell the patient, but I don't think that we do that very often. Ruben, do you do kyphoplasty? Yeah, you do that? I think.
No, I don't.
You don't, but we send patients to interventional radiology. And Dr. Bhutani, Divya, when was the last kyphoplasty you sent?
It's been less and less, I think.
Less and less, yeah. But I have to say, it's an elegant method. So what do? So patient with a fraction of their vertebral body, you see, this is the spine, and you see here this wedge fracture. And what we do, we can insert a needle into that collapsed vertebral body, and we can inflate a balloon. And you can fill the balloon with cement, and you can see that the end plates, the upper and lower plate kind of, elevate. And you can reproduce the regular structure of the vertebral body. And the nice thing is patients have an immediate benefit, less pain from a vertebral fracture. It's a very elegant outpatient procedure. And I think 10 years ago, we did it pretty often.
Why is it done like that?
You know what? I don't know. I think at least in New York, we see patients earlier and earlier. Yeah, we have medications that work so fast. If I put a patient on KRD, carfilzomib, Revlimid, and Dex, there's an immediate response in most of the patients. And also with a response, the pain usually goes away. So you don't have that, I don't know, it's not that demand. And there was a little bit of concern. If you put cement into that vertebral body and you stabilize it, it's stiff. You still have very frail bone beneath, above and beneath. Is there an increased risk of fracture in the vertebral body above and below? Those were some concerns, but just in case it still exists, and it's a nice method. So, but what do we do to treat multiple myeloma bone disease? What do we do? The bisphosphonates, exactly. Zomera aurelia, yeah. So also the latest child, denosumab. How does it work? So it's very easy. I love the concept of bisphosphonates. It's really, I think that person who invented that should get the Nobel Prize because it's such a great idea. Look at this. This is the bone, yeah? This is the bone. Here you have the osteoblast. The green cells are the good ones. Green is always good. So the osteoblast, they produce the bone. You see, this is a new bone. And this ugly big cell is an osteoclast. And the osteoclast eats the bone, yeah? It sits there and it's doing bone resorption. And why is this? The osteoclast is activated from the myeloma cells. The myeloma cells give a lot of signals to the osteoclast. We don't know exactly why. Please be active and eat bone. So what the bisphosphonates are doing, when we give you bisphosphonates, they go to the bone and they bind to the bone and they sit in the bones. They bind to the hydroxyapatite. That's a structure or that's a chemical structure in your skeleton. So the bisphosphonates are concentrated in the bone, and what the osteoclasts are doing, when they eat the bone, they release the bisphosphonates and take up the bisphosphonates and they die from it. Or they are less inactivated. So it's I would say, a targeted therapy. No other cell would resorb the bone, and that's why the other cells do not really take up the bisphosphonates. So you paralyze or you inhibit the activity of the bisphosphonates, or you promote also apoptosis. We learned what it is. Dr. Nesvitsky showed that nicely. It's cell death, so they die. Also, we think that if the osteoclasts, the bad cells, the bone-eating cells, that's what I tell my patients, if the bone-eating cells have a decreased activity, that the osteoblasts, the kind of good cells, can recover with their inhibited activity in multiple myeloma. So we have two types of bisphosphonates, two types, Zometa and Aridia. Who received Zometa? Most of you, I guess. Aridia, anybody on Aridia? Yeah, so Aridia. So they're both pretty much the same. Yeah, so you can get Zometa or you can get Aridia. You can see if you look for patients with events, if you see SRE, this is skeletal related events, fractures, need for radiation, pain, new lytic lesion, anything that is shows that you have bone disease. So both again, drugs have the same ability to inhibit or decrease skeletal related events. Bone disease, you can see that there is no difference. But why do we use Zometa? Anybody an idea? Why do we use Zometa?
Quicker.
Right. It's much faster. It's 15 minutes versus Aridia, it's an hour, 2 hours. Yeah, 2 hours. In patients, and I will talk later about that, in patients with renal disease, sometimes I take Aridia. But again, I talk later about this. So most of the patients take Zometa. And there was a large trial, and I would like to show you the trial in order to really underscore the importance of bisphosphonates. It was a trial in the UK. And what they did is with 2,000 patients, so a large myeloma trial, what they did is they randomized newly diagnosed myeloma patients. So the patients who had just the diagnosis either received zoledronic acid or they received clodronate. That's an oral bisphosphonate. We don't use it here in the States for multiple myeloma, but they wanted to know really, do we need to give an IV medication each month or can we just give a pill and what is better? And what do you see here? You see here the number of patients who had a skeletal related event. So who had, for instance, a fracture or needed radiation or had new lytic lesion. And in orange, you see zoledronic acid. So around 5% within 2 years, around 5% of the patients within 2 years had an event in their skeleton. In contrast, patients who received the oral bisphosphonate, the clodronate acid, had a much higher risk to develop skeletal-related events, almost 10%. So the risk doubles. So it showed that Zometa is much better than clodronic acid in prevention of skeletal-related events. And they also, unfortunately, found that the more you inhibit the occurrence of lytic lesion, the higher is the risk of ONJ. You can see that here. So with Zometa, it was 3.7%, and with clodronate, it was 0.5%. ONJ is osteonecrosis of the jaw. It's a bad side effect of the bisphosphonates. How do we diagnose this? I didn't show a picture because sometimes the medical pictures look ugly. I mean, I always, when I give a presentation to you, I always think, can I show that to my mother? So she is my guidance, for this, and she would say, "Woo, don't show this." So that's why I didn't show a picture. Should I? Jennifer, what do you think? It looks, it's exposed bone, exposed bone in your mouth. So patients come and say, "Hey, doctor, you know what? I found there's a sharp thing in my mouth, everybody's trying, there's a sharp thing in my mouth. Is it exposed bone?" And sometimes we see just the bone, looking through the gums, and also pieces of bone can come out. Usually, when we stop the bisphosphonates, that's okay. We just have the exposed bone. But in the past, we saw really bad ONJs. And I had one patient, I think 50 years ago, she needed a replacement of her lower jaw because there were fistulas. It was really bad. So if we know much better how to deal with bisphosphonates, but the ONJ is something we fear a little bit only. So there's always a discussion, when should we give bisphosphonates? Should we give it when patients have lytic lesions, when they have bone disease, or should we give it to all patients when they have a newly diagnosis of multiple myeloma? And again, everything developed, and what I show you is the result of, I would say, awesome recent research. If you didn't get bisphosphonates maybe 10 years ago and you were diagnosed, the doctor can only treat you according to what the doctor knows, This is what we know right now. And we found in this large study with 2,000 patients that patients who had already bone disease at the baseline, when they started treatment for multiple myeloma, when they received Zometa, they had a decrease of skeletal-related events. You can see that the red line in comparison to the oral medication to the clodronate. But what about patients without any bone disease? You can see that even Zometa prevented the occurrence of bone disease with much lower bone disease in comparison to clodronic acid. So what does it tell us? So right now we treat all patients who have a diagnosis of multiple myeloma, regardless whether they have bone disease or not, with Zometa. So if you have a diagnosis of myeloma, please remind your doctor, that you also need Zometa. I'm sure that next time I see some of my patients, they will say, Dr. Lentzsch, you didn't give me Zometa. It can be difficult, especially when you get a transplant. The transition of patients to transplant when you have other problems always kind of, might lead to, I would say, a break in the Zometa. But just keep in mind, restart Zometa. You should take it for a year or for 2 years. There should be a saturation of your skeleton. So I talked about ONJ already. Who are the patients who develop ONJ, that osteonecrosis of the jaw? Remember the picture I showed you with the osteoclast that's eating the bone? So you can imagine if you have infection in your bone, you need osteoclasts because they eat the infected bone away, the decay, the bacteria. They clean kind of, in the area where you have your dental infections, they clean that area. If you stop that, the infection might go on, but also the old bone stays there. Oops, you have no cleaning tool. And that's a problem that we know that patients with a bad dental status have a higher risk. So that's why what we do is we send our patients before they start bisphosphonates for a dental, I would say, clearance. So they need a dental checkup. Some patients come back and say, I need several root canals and I need, a removal of teeth. And we say, do this before you start bisphosphonate, because if you have that infection and on top of that we give the Zometa, you might have a higher risk of ONJ. The problem is I have some patients who like to delay the dentist, and I just realized that there's one patient who is on the 8th cycle of RVD and still is waiting for dental clearance, and I said, we have to give bisphosphonates now. So please go to a dentist if your doctor asks you to do this. So we try to avoid invasive dental procedures. Sometimes we can't, yeah. If there is a bad tooth and we need to take out the tooth during the bisphosphonates, we have to do this. Usually we stop the bisphosphonates, we give antibiotics, we talk to the dentist who's doing this, and I have to say with all the procedures, I rarely see ONJ. I mentioned poor oral hygiene, so that's important when you're on bisphosphonates. Also duration of multiple myeloma. We know that the longer you're on bisphosphonates and the longer you have myeloma, the higher is the risk. And we learn it the hard way, and that's why we stop usually the bisphosphonates after 2 years and give patients a break. How can you reduce the risk? What can you do as a patient? Again, monitor your dental status, treat dental problems before you have the bisphosphonates. Also, you can say, oh, I had the bisphosphonates, I'm on a break. In case you have a relapse, before you restart with bisphosphonates, go and talk to your dentist. Avoid invasive dental procedures during treatment. I know, we have to do what we have to do sometimes, but be aware and discuss it with all the doctors. There was a study from Dr. Badros who looked for patients after occurrence of ONJ. How are they doing? Around 97 patients. And some of the patients had really stable ONJ with no further progression, but they had the exposed bone their whole life. Some of the ONJs will heal. Usually we say once you have ONJ, it will never heal, but some of the ONJs kind of, went into a healing process. But what we do when you have the ONJ, we stop the bisphosphonates. And that's a problem if you have new active bone disease. You really try to avoid to give bisphosphonates, and you have to decide that with your patients, how bad is a bone disease and do you really have to restart the bisphosphonates. So there's a lot of discussion on, do we really have to give the bisphosphonates every month, or can we do it also every 3 months? And I just want to mention a study from Dr. Raja. What she did is she did based on bone resorption markers. There are markers that tell us how active is your bone resorption or how fast is your bone is destroyed. One of the markers is the urine NTX. So based on the markers, she did the following. If the markers were very high, she gave the Zometa every 4 weeks. If the markers were low, showing that there's low bone resorption and you don't have active bone disease, the Zometa was given every 12 weeks. And the study was pretty successful. It showed that even if you stretch the intervals of Zomera and you give it every 3 weeks, you have a relatively low event rate of skeletal related events. It was 5.8% over the 2-year study period. And you also have a relatively low incidence of the osteonecrosis of the jaw. And they showed, and that's what we do, especially in patients who had already a lot of bisphosphonates, we try to stretch the intervals. So if you are on bisphosphonates for a long time, maybe for 1 or for 2 years, you have really bad bone disease, I think it's time to discuss with your doctor, what do you think? Can I stretch the intervals or can I stop it? I hate to give recommendations because your doctor has the full picture. I don't have this, so it's always give general recommendations, but I want to give you some kind of, I would say inspiration to digest and some discussion with your doctor the next time. Have you heard about denosumab? Denosumab or Xgeva? It's a new medication. It was just recently approved for the treatment of bone disease and multiple myeloma. It's in rank ligand. It works in a different way. It doesn't really goes to the skeleton. It inhibits the cytokine that we need to activate the osteoclast. So it's a rank ligand inhibitor. It's also used in other cancers, breast cancer, for instance. And the nice thing is it's given subcutaneously every 4 weeks, so there is no infusion. And you can give it even if you have renal failure. That's very nice. And the study, and the denosumab was tested in comparison with zoledronic acid. Also here you can see a large study. And you could see denosumab and zoledronic were equivalent. So there was no winner. They both could inhibit the skeletal related events to the same extent. Unfortunately, we were hoping that with denosumab, the ONJ rate is lower, but it wasn't. It has a similar ONJ rate. So it shows us once you stop, remember that I told you about the infection, once you stop the resorption of decayed bone, probably you have a higher risk of ONJ. Problem with denosumab, it really induces hypocalcemia. You know what that is? Calcium is low. Calcium is very low. Your calcium in myeloma is high, it's part of the disease, but the denosumab can do the opposite. And if your calcium is very low, it can be also dangerous. So everybody who is on denosumab needs to be also on calcium supplements. That's important. Everybody should be on calcium supplements, but it's especially important with denosumab. It is a potential novel treatment, but again, we could steal some information from endocrinology and from our colleagues from breast cancer who are using denosumab already for a long time. So what happened with denosumab? When you give denosumab, you block certain cytokines that activate the osteoclast. Yeah? When you take away the block of the cytokines and the block of the activity, there is a rebound activity. So we see after the stop of denosumab an overshooting activity of the osteoclast resulting in massive bone resorption and even fractures. So our endocrinologists, our endocrinology colleagues saw this, and there is a recommendation, if you're on denosumab and you want to stop it, you need a couple of months overlap with bisphosphonates, Zomera, to bring down the activity of the osteoclast. So to make a long story short, I think we so far still kind of use Zomera for most of the patients. In certain cases, we use with patients with renal failure, where it's a problem, then we use Xgeva. I don't know. We have a lot of experience with Xgeva.
Yes, we're using
Yeah.
it more often now.
More often, yeah. So it's always probably also for us a learning curve. So when you are on bisphosphonates, it's very important that your doctor is regularly testing your renal function. So each time before you get bisphosphonates, you should have a creatinine. If the creatinine is really high, the doctor needs to adjust the dose of the bisphosphonates. That is true for Zomera, but also for Iridia. We can decrease the dosages. We know that those medications can be a little bit toxic for the kidneys. And we know that the toxicity comes from the, I would say, concentration of the drug. So if you give an infusion very, very fast, you have a high concentration in your blood, and that is toxic for the kidneys. If you give the infusion slowly, the area, we call that area under the curve, or the increase of the concentration is slower and doesn't achieve that peak, and with a lower, I would say, concentration in your blood, you have less toxicity to the kidneys. So that's why what we do is, when I see that patients do not tolerate the bisphosphonates, Zomera or Iridia, I prolong the infusion time. some of the patients, I remember the good old days, were 4 days of Iridia. 4 days, 4 hours on Iridia. That can be quite cumbersome, in addition to all the other IV medications. So go slow when you have any renal toxicity. Also, Zomera and Iridia affect different, I would say, anatomical structures in your kidneys. If you see that your creatinine goes up after Zomera, you can try Iridia. Also, if you have side effects from Zomera, some patients have a little chilly or bone pain after the first infusions. You can also switch to Iridia. Again, I mentioned that both drugs are similar in their potency to inhibit or depress bone disease. It's important that you monitor the creatinine, and it's important that you stay hydrated. So if you have really bad diarrhea or a viral bug and you come to your doctor, or you don't see your doctor, you just go and get Zomera and you're pretty dry, it can be more toxic for the kidneys. So make sure that you are hydrated, or ask your doctor, can you give me some fluids to hydrate me? Okay, everybody's taking out the bottles. Yeah, that's a good idea. Also, talking about kidneys, just that everybody is aware, nothing to do with bisphosphonates. Try to avoid NSAIDs. When you have multiple myeloma, NSAIDs, non-steroidal anti-inflammatory drugs, Aleve, ibuprofen, help me. I have also chemobrain. Advil, yeah, don't take it, don't take it. Take a Tylenol, take OxyContin, whatever, that's good for you, Because those NSAIDs can be toxic in myeloma patients. I had myeloma patients who went on dialysis for a short time, after bone disease, bone pain, and then good amount of Motrin, and it didn't it's really not good for your kidneys. Just as a side information.
Sorry, how do we know it's a bone pain or it's a muscle pain?
Ask your doctor. Yeah. No, really, that's what I tell my patients. I said, if you have any bone pain, call us. Don't go to a chiropractor, and we are very generous in multiple myeloma with x-rays. Yeah, in general, you would say if you have a back pain, maybe it's a muscle pain. But in multiple myeloma, I start usually with an x-ray. And if you have really bad pain and the x-ray doesn't show anything, then I do a CT scan or an MRI. Yeah. So unfortunately, imaging is the only thing that can really tell you what's the difference. Again, I talked already about how do we monitor renal function with bisphosphonates. What do you do in case you really have bad renal function? Your creatinine is already elevated, or you have a low filtration rate. We call that GFR. If your GFR, the filtration rate of the kidneys, it's milliliter per minute, if it is really below 30, if it is very low, your kidney function, then bisphosphonates are not indicated. Then usually we cannot give bisphosphonates. And in those cases right now, I think we have the good alternative to give patients Xgeva. When you are already on dialysis, then we can give bisphosphonates. It sounds brutal, but if the kidneys are already so much damaged and there's no recovery, then we can give bisphosphonates because there's no further kidney damage expected. When you have hypercalcemia, really high calcium, 13 or 12, in those patients, the kidneys are very stressed from the calcium. And those patients, we also try to avoid bisphosphonates, and we give fluids, and we try to reduce the hypercalcemia and give the bisphosphonates once the kidneys recover a little bit from the hypercalcemia. Patients very often ask me when they have MGUS or smoldering multiple myeloma, okay, I don't need treatment for multiple myeloma, but what about if you give me bisphosphonates? It's not a chemotherapy, and maybe it prevents that I get multiple myeloma bone disease. There were some studies with bisphosphonates, and they showed that, for instance, here in a phase 2 trial, you increase the bone density, and there were also some trials that you lower the number of skeletal-related events, but in general, outside of clinical trials, we do not recommend to give bisphosphonates. We really wait until patients have an indication for multiple myeloma. Why do we do this? I think, first of all, patients can be in a long phase smoldering myeloma. I have patients I follow for many, many years. They are doing very nicely. Why should I risk to give them a medication that is potentially renal toxic for the kidneys, can potentially cause an ONJ? Maybe the patients with a smoldering myeloma receive bisphosphonates, develop ONJ, and that does not allow me to give bisphosphonates later, and when they really need it, when they have overt bone disease, then I blocked my own treatment. So outside of clinical trials, usually no recommendation for bisphosphonates for patients with smoldering myeloma or MGUS. So the International Myeloma Working Group gave guidelines how to use bisphosphonates, and again, we can give zoledronic acid or Iridia, that is recommended. We give it when all patients, and that's important, who have a new diagnosis of multiple myeloma should receive bisphosphonates. I always want to repeat this. And interestingly, zoledronic acid and the study I mentioned also showed that there is a slight increase in the overall survival. We don't really kind of use zoledronic acid to say I want to prolong your survival, but it's a very nice side effect. It was only 4 months in that study, but I think it was significant. So that's why I think the combination of zoledronic acid together with chemotherapy is very helpful for our patients. So in summary, so multiple myeloma is kind of the most common cancer that involves the bones. Almost all myeloma patients have somehow skeletal-related events. It can be even a low density of your bones. Some patients come from endocrinology with a diagnosis of severe osteoporosis, which we cannot really explain otherwise. A young athletic man in his 50s should not have osteoporosis. So those things can also lead to the diagnosis. Imaging is critical, I mentioned this. We will change imaging in the future in the US. You will see more and more whole body low dose CTs, but also whole body MRIs. That will be an interesting development because we will see much more other diseases that might come up with the MRI if you do this. Again, discuss with your doctor whether you want to switch to Iridia if your kidneys suffer each time you receive your Zometa and you see that their creatinine is going up. And we are working on bone disease, and especially my laboratory is working on multiple myeloma bone disease to come up with new treatments for this devastating condition. And you might recognize one or the other in our team. I know David needs to go on Weight Watchers. I told him this, but nevertheless, he's doing a good job. Thank you so much.